All right, the next one here is from health coach Ann Sandberg from South Dakota. It says, could you speak to the language used between SCI and Alzheimer's disease? The neurologist gave my client's husband the distinct impression that his wife has Alzheimer's disease. Her brain scan showed a, quote, 30% capacity loss, end quote. Does this mandate a diagnosis of Alzheimer's disease? Right or wrong, my understanding is more nuanced, seeing AD as the final stage in a progression. Especially at the beginning, I don't tend to use the word disease. I explain that they have a condition that can be treated and use phrases such as Alzheimer's type cognitive concerns or Alzheimer's type dementia. I'd like to leave some room for hope and change. So you've really hit the nail on the head here. And here's why. Here's the problem, and this is a problem in nomenclature and should be addressed. Dr. Alzheimer in 1906 described this. It's a pathology. And you have the three big things. You have the plaques, which are mostly amyloid, mostly A beta, 40 and 42. You've got the tangles, which have turned out to be largely phosphorylated tau. And then you've got the microglial investing, microglial activation. So you've got some degree of inflammation. So you got those three things together, which are classic. And now you're downsizing, you're losing synapses, et cetera, over time. So strictly speaking, by pathology, when you look at the clinical stages, which are asymptomatic, where you're already seeing a high p-tau or a high GFAP, for example, you still got plaques and tangles there. You're just asymptomatic. You haven't lost enough synapses yet. Then you've got the phase 2, which is SCI, subjective cognitive impairment. And by definition, that means you notice some problems, but you're still able to test normally on standard cognitive testing. Now, the problem there is the doctors say, oh, you're just aging. That's all. This is normal aging. And they chalk it up to that, which is really unfortunate because it's very easy to bring that back to normal. So it's a good time to address things. The third stage then is what's called mild cognitive impairment. And as one patient said, there's nothing mild about it. They're having problems, with memory. They're having problems with executive function often, things like that. It's really a relatively late stage of the problem. Now, by definition, you're testing abnormally on cognitive testing. And then, so the SCI lasts on average 10 years. MCI, 5 to 10% of these people each year convert to dementia. And by definition, that means you've begun to lose the activities of daily living. And so when you look at the trials, including our own trial and including the drug trials, they are MCI and early dementia. So they're not including people with SCI or asymptomatics. That's where things should go. And now that we have better biomarkers, presumably they will go. But that means you're going to have to follow up people longer. What we see is when people have SCI, you do the right thing, you identify what's causing the problem and treat it. Virtually all of them improve. And Anne, I know you've treated a number of people with SCI. What's your experience with people who have SCI?
Yeah, it's oftentimes people who do some kind of complex work or they run their own business and no one else notices any problem, but they notice it. They're like, oh my gosh, I'm having trouble. I'm forgetting my clients' names. I used to always hold their whole picture, their name, their history, exactly what I'm doing for them. And now, I have to write everything down. That's such a common thing. And a lot of times it's people in their 50s and or early 60s, and a lot of them carry one or two ApoE4 genes. And we have amazing success with those people. They still see me once a year after maybe 7, 8, 9 years of being fine. We check in on everything, repeat their cognitive testing, et cetera. But those people who come in for SCI, first of all, those are smart people, right? they they know something's wrong and they seek a solution, right? That's the opposite of certain people who are much more prone to feel like, oh my gosh, there's a problem, and they want to avoid really thinking about it, right? So yeah, those kind of people who are subjectively, they know they're not well, they're not cognitively intact as they used to be. They do amazingly well.
Yeah. And this is where standard doctors pat them on the back and say, "You're getting a little older. That's that just happens." And I think they're losing a huge opportunity to prevent dementia in the future because these people then just go right on to having MCI, et cetera, if you don't do something about it. Now, to your point though, and what's happening here is by definition, all of those four are Alzheimer's disease. They all have plaques and tangles. Now, the asymptomatic phase may not have the microglial, the inflammation part, as that's what tends to give you the symptoms. But they're all pathologically Alzheimer's. I kind of like the idea of doing just what we say when we have pre-diabetes and diabetes. I like the idea of calling the asymptomatics and the SCIs pre-Alzheimer's and the MCIs and the dementias Alzheimer-related cognitive changes. But that's not accepted yet, so we'll see where it goes. Strictly speaking, they're all Alzheimer's, but it's Alzheimer's related asymptomatic state, SCI, MCI, dementia. And so the term Alzheimer's scares people, unfortunately, but you're absolutely right in that you should be reassuring them, no, that just because you have those pathological changes does not mean that you're necessarily going to get worse. It doesn't mean that we can't treat it. We see improvements all the time. And that's exactly what the trials have been about. And again, the earlier you start, the better off you are, the less chance you have of progressing, and the more you identify the things that are driving this. Great idea to use those biomarkers. Find out can you get their p-tau 217. Now, if you see someone who's asymptomatic, but they've got a high p-tau and a high GFAP, they've got some inflammation going on, they got some Alzheimer's processing going on, and they're headed for SCI. But if you see them and their p-tau is a little high, but their GFAP is completely normal, they have a relative, and their NFL is normal, they've got a relatively quiescent state there. And you still can address it. You can still optimize their health, their blood flow, their oxygenation, all the things that we always talk about. And they should do well for many, many years to come. So again, knowing all these things together really gives you a good handle on what's going on inside those brains and should allow us to make Alzheimer-related dementia really a thing of the past, or at least a very uncommon thing. So I think these biomarkers are going to be very, very helpful for a lot of us, which is why I just had mine checked a couple of weeks ago. Very happy to see that they were all fine, and I will get them checked again in 2 years. So I'll see how things are going in 2 years. And what would you recommend here for Ann Sandberg?
Well, I think she has the right attitude. I mean, certainly, a doctor saying your brain scan shows a 30% capacity loss is a meaningless statement to me. I don't know what he's talking about there, he or she is talking about. But I think her attitude that, you want to call it some kind of Alzheimer's related condition that is addressable, that is certainly reversible, et cetera, is an optimal way to help the person understand that this is not a fait accompli. It's a process that can be reversed at all of the early stages. We have research that shows that it can be reversed at all the early stages. So, you can certainly provide a diagnosis and at the same time provide hope and encouragement and positive message to the person, and remind them that there are still a lot of physicians out there who don't have that attitude, and to some degree you're going to have to ignore them to be on this track.
And I would, point this person toward a few of the papers showing improvements in cognition. The trial, for example, these are freely available online. Also, please let us know what you mean by 30% capacity loss. Do you mean that there was a decrease in volumetrics like hippocampal atrophy? Do you mean that this is an FDG PET and there was a 30% reduction in fluorodeoxyglucose uptake? I don't know what you mean by 30% capacity loss. That would be important. It's coming from a quote, a brain scan. So is this a PET scan? Is this an MRI?
Yeah, that's what the neurologist said. Uh, so,
so it'd be helpful to know what do they actually mean here?
what were the actual findings on the brain MRI? That's what we'd like to know. Yeah,
And
absolutely.
was it an MRI or was it a PET scan or was it a SPECT scan? What was it? So, all right, that's helpful.